webinar series dedicated to research and evidence-informed practice. My name is Deb Hill, and I manage our project to enhance research literacy here at the Academic Consortium for Complementary and Alternative Healthcare, otherwise known as ACAC. And we are the host organization for the webinar series. This is produced in conjunction with the Alliance for Massage Therapy Education, the Commission on Massage Therapy Accreditation, the Massage Therapy Foundation, as well as the National Certification Board for Therapeutic Massage and Bodywork. So welcome, everyone. A little bit of housekeeping up front. All attendees will be in listen-only mode, and you can type questions in your control panel, and we'll try to get to as many of those at the end of the webinar as possible today. And the session will be recorded, and this will be posted a little bit later on our website. So I wanted to start off today, for those who might be joining us for the first time, with a very brief introduction to ACAC. Again, we're the Academic Consortium for Complementary and Alternative Healthcare. And really, we are a broad, multidisciplinary organization that fosters interprofessional collaborative care. We consist largely of 5 core professions. Each of these professions have a programmatic accreditation body that is recognized by the Department of Education, and massage therapy is one of those core professions. So altogether, through our member organizations, we're linked to about 375,000 licensed healthcare providers, as well as about 180 accredited institutions and programs. And we really work to advance the values, practices, and disciplines with integrative health and medicine. So without further ado, I want to go ahead and introduce our panelists for today. First, we have Clint Chandler, and actually, I'll say good afternoon, Clint.
Good afternoon.
And Clint has over 24 years of both clinical practice and teaching experience in massage and manual therapies, with an additional 8 years working as a multidisciplinary team member in a physical rehabilitation hospital. Clint has co-authored and published papers examining the effects of massage therapy on chronic tension headaches and carpal tunnel syndrome. So thank you for joining us today.
Great to be here.
Next, we have Nikki. Good afternoon, Nikki. Nikki Monk.
Hey there.
Hi, Nikki is an assistant professor of health sciences at Indiana University and the practice section editor for the International Journal of Therapeutic Massage and Bodywork. Dr. Monk's research focuses on massage therapy, efficacy, and effectiveness for pain function across the lifespan, as well as the impact of massage-related case reports. So welcome, Nikki.
Thank you.
And do we have Ruth? Okay, Ruth will join us shortly, but we will have Ruth Werner on in just a minute. And Ruth is a writer, educator, and retired therapist. Her textbook, A Massage Therapist's Guide to Pathology, is now in its 5th edition. She also writes for Massage and Bodywork magazine and teaches workshops all over the world. Ruth has served as the president of the Massage Therapy Foundation from 2010 to 2014, and she continues to be a trustee for the foundation. And we'll go ahead and welcome Pete. Hi, Pete.
Hi.
Pete Whitridge is the president of the Alliance for Massage Therapy Education and is a faculty member and former director for education for the Florida School of Massage in Gainesville, Florida. He's also the past chairman of the Florida Board of Massage Therapy and past legislative chair for the Florida State Massage Therapy Association. Pete is also an NCB-TMB approved CE provider. So welcome.
Thanks for having me today.
Okay, so we're going to go ahead and get started. We have quite an agenda today. Should be an exciting webinar. We're going to cover a lot of ground, and we're going to start with a brief introduction to journal clubs, and then go ahead into a real example, or a real life. We're going to hear from Clint, who has actually run a journal club for massage therapy, and then we're going to present and discuss a research paper that we found on our last webinar and summarize. So we're going to start out today with a simple definition of a journal club, which at its nuts and bolts is really a regularly occurring small group meeting with the purpose of reviewing, discussing, and evaluating research literature. And while there's many various formats, and this is not an exhaustive list in any means, but I wanted to give out some ideas to kind of get the ball rolling. One way is to meet face-to-face, possibly with a breakfast, a lunch, or a dinner. Sometimes food helps to get folks together. An electronic format might include something that we're doing today, or a blog or a discussion board, and the Joanna Briggs Institute actually has a nice online journal club. And then finally, I pulled out some information from the nursing literature of what I call break room based, and this is really great for folks who are scrunched in time. And so this is where maybe a traveling poster critique is exchanged between various practice settings with an evaluation form that could be completed by those reviewing the poster appraisal, or a A reviewer is present in the break area for about an hour, and participants can rotate through in 15-minute shifts and really discuss the article and answer some questions. So I just wanted to give you a brief overview of a couple examples, but I do want to have Clint take it away from here in terms of really presenting a club that he has actually successfully managed. So Clint, I hand it over to you.
Okay, thanks, Deb. Well, we talked about, I think in the second webinar, I presented the idea of a journal club, but I think a lot of people in this industry have met this with great challenge. I think the traditional journal club is probably, too formal and probably too academically oriented for most massage therapists. So what I did was formed a group called a consultation group, and it began by just getting therapists together to meet, get advice, and discuss difficult client situations. You can move it to the next slide, Deb.
Okay.
I don't know if you need me to cue you. Yeah.
Yeah, I do need you to cue me. That'd be great.
Yeah.
Thanks.
With the primary goals of this group was to provide a platform for professional camaraderie, reduce the feelings of isolation that a lot of therapists experience in private practice, try to provide support and resources to therapists. And then, this was kind of a hidden agenda on my part. I integrated later on the utilization of current research information. The group began with discussing difficult client situations, and that was really well received by the group members. You can change the slide. So what happened initially in these journal clubs, what I found is that people are always asking me, why is there never a hands-on component? I mean, massage therapists are kinesthetic learners. They want to do stuff with their hands, and so most of them are looking for some kind of new approach to integrate into practice immediately. So what I learned over the years in doing this group, I did it for 6 years. I haven't done it for the last 3 years. But blending the research content and hands-on seems to be an easier stepping stone, if you will, to what people consider difficult or often scientific material that they don't seem to be interested in. You can switch the slide. So the challenges of a group like this are obviously the article selection is a critical component of such a group. What I learned, I was excited about some of the early research that was done by Dan Shurkin up in Seattle with low back pain. But when the therapists read those articles, there was a lot of statistical analysis data in those papers. It was really hard for them to kind of, wade through that. So I learned to start with case studies. I think it's a good starting point. They're a little bit easier for therapists and students to read. They also particularly like studies that are written from a clinical experience point of view that speaks to them as a practitioner. So I tried to find articles where massage therapists were included in the research project as co-authors or had some instrumental role in the research project. I think those are, a good starting point. You can switch the slide. The group structure that I had is we met the first Monday of every month at 6:30 p.m. and for a 3-hour block of time. And most people would cringe at 3-hour block of time, but you'll understand it as I explain this. I had 6 professional therapists that worked within this group. And the ones that I found that were the most, and I don't know if successful is the right word to use, but the ones that got the most out of the group and had the greatest attendance were those therapists who were in private practice. I think there's a greater deal of motivation when you're in private practice to learn what's going on in the current literature and getting new ideas on how to approach people and work with certain conditions. The people that also seemed to do well with those that had some formal educational background where they had to do some kind of research in their formal studies, and those that were on a second or even third career path. So that was kind of our structure. We met once a month and for a 3-hour block of time. You can switch the slide. So a typical schedule would work something like this. We would do an article review for about 45 minutes, and every other time I would alternate with a difficult client situation. They love to bring case report type things, difficult situations that they were dealing with in their practices. So the article review didn't happen every month. We did that every other month. And what we would try to do is couple whatever the article title or subject or topic was we would try to couple that with a hands-on demonstration. Sometimes I'd demonstrate if there was a good protocol in the paper, I would try to demonstrate that protocol to them. We would take a break for about 10 minutes, and then we would practice the hands-on component of that, the research study. So group 1 for 45 minutes, and then practice group 2 for 45 minutes. The end of that group would be a cleanup, and then we would either, I would either give the assignment that the next person could choose the article for the next month's consultation group, or so we worked that out. It just kind of went every other month with talking about difficult clients, and then a month of where we would do an article discussion. So that's what I called a consultation group. It's a little bit of a hybrid, I guess, of what a journal club, the traditional journal club, is.
Clint, that is great. That's a great example, and I actually like the hybrid. I think that it gives you that hands-on and really kind of putting that research into practice, as you said. If you have a protocol that you could go ahead and kind of work through together, that sounds like a great opportunity.
Yeah, and I also taught this in a class, a 60-hour class, this structure as well. It was called Clinical Massage and Evidence-Informed Practice, and obviously students weren't as receptive as practicing professional therapists, but they liked the hands-on part, but they didn't really like the article reviews so much. But yeah, I've used it in 2 different kinds of settings.
Oh, that's great. So both educational and kind of out in practice.
Right.
Wonderful. Well, this is great because I wanted to everyone to hear of a successful club specifically in massage therapy. So thanks so much for sharing that today. We're going to move on to today's journal club presentation, which is really based on a format that was outlined by the National University of Health Sciences, and this is one of the contributors to our project to enhance research literacy. And for those of you who are looking at the bottom of the slides, all of these slides will be available on our website, and each of you have registered will have an email follow-up when they're there, and you can take a look at the references. But the National University has a lot of great references in terms of some worksheets to help you walk through the journal club and some great examples. So I highly recommend visiting them. So based on our last webinar, we went ahead and did the first 2 of these topics in terms of the journal club. We chose a topic based on a clinical question. And for review, our clinical question was a 45-year-old woman with diagnosed osteoarthritis of the knee. And she was looking for a way to really reduce the pain associated with that, and had come to you as a massage therapist in your practice. So we went ahead on that webinar too, and that webinar was recorded and it's freely available on our website. And we searched the literature to find an article that we thought we'd like to take a closer look at, and that's where we come to today. So we're going to go ahead and present this paper really in somewhat of a modified traditional format, going through it step by step. We'll discuss and evaluate as we move along instead of at the end. And then really with the end goal then is to determine if this research applies to our clinical case in question. So with that, I wanted to go ahead and start with the traditional presentation, which is the title slide, which is Massage Therapy for Osteoarthritis of the Knee, a randomized dose-finding trial. And this was conducted in 2012. Dr. Adam Perlman is the lead author on this paper, and this is a free full-text, freely available article. So we wanted to take a closer look at this one. And we start with the introduction component, which really tells the story and kind of sets the stage for why the research should be done. And just a basic overview and some background is that the U.S. demographics will show that osteoarthritis of the knee is really expected to increase, and it is costly. And with that comes an increased demand for non-pharmacological interventions. And the author's own study in 2006 showed an improvement for osteoarthritis of the knee with full-body Swedish massage. To date, there had been no dosage studies done, and really then the purpose of the study was to determine the optimal dose of massage for osteoarthritis. So did any of our panelists want to go ahead and comment on the introduction and if they thought this really set the stage for why the research should be done?
Go ahead, Ruth.
Thank you. Hi. Because I write and teach pathology, I often sort of have that as a filter when I'm looking at studies like this, and I just loved this introduction. I thought it was really clear and easy to follow and makes a really compelling case. What I found maybe missing in terms of looking at the the expense, the costliness of treating osteoarthritis is both the cost of long-term commitments to painkillers, and also the cost of joint replacement surgeries, with the understanding that they have a limited life expectancy, and so especially someone relatively young who has to replace a knee, may be looking at repeating that surgery, one or two more times with an increased risk of failure with each time. So, I think that showing to do a dosing study is a great idea, but I think this opens the door to so many more exciting questions. So, the introduction just really got my juices flowing about not only this study, but what comes next.
Well, I think it also does a really nice job of laying the framework for this research line, because it does talk about the pilot study that was done back in 2006, that was reported on in 2006, and how it was a small pilot study. The participants were not terribly generalizable, and so the next step is to do a larger trial, and part of that was they also needed to figure out, for money-saving pieces and to be as economic as possible, to get that optimal dose. In that original study, they had 1-hour massages that were completed twice a week the first 4 weeks, and then the second 4 weeks was once a week. And so they needed to, first of all, manualize the process by which they were going to apply the therapy, and then to figure out what was going to be the best dose for the next follow-up study that's actually currently in production.
Nikki, can you define manualize, please? Because I ran into that also in reading the associated paper, and I had to kind of struggle with what that means in this context.
So basically, systematically develop and be able to document what the treatment was.
Right.
Great.
So can I make one other comment about that? There's
do.
also an interesting aspect of this. There's a growing body of evidence that arthroscopic surgery for osteoarthritis of the knee is not any more effective than sham, and it's also not any more effective than PT. So this is also probably would be a great component. I'm sure they'll add it into the next introduction of the paper that they're doing, but I think that's an important, because it's also interesting to note how many of these people had surgical intervention that then evolved into osteoarthritis.
Mm-hmm. Good comment there.
And another point here too is people are always asking, how many treatments should I have, or how often should I have treatment? So this is a very helpful beginning studies to point the way as to what we can answer that question.
Mm-hmm.
Perfect.
Right.
All right, so I think we're in agreement that in terms of the introduction, it really set the stage and helped us move onward with the study series. So the next section, we're going to break into a number of different ones, and this is in terms of the methods section, because it's really the nuts and bolts of the study, if you will. And in this one, basically the participants, we'll start with the participants, there were men and women, 35 and older, with diagnosed osteoarthritis of the knee. They had multiple exclusion criteria, including knee injury or recent corticosteroid use. And they were allowed, it's really interesting, to continue pharmacological pain medications if they were kept constant. So I thought I would open this up and see if any of you wanted to comment really on the participant portion of the method section before we move on to the study design.
I have a comment. The American College of Rheumatology criteria, their clinical criteria is that the participants are 50 years and older. So, and also that the radiographs have demonstrated osteophytes. I didn't see that anywhere in their participant description.
Great catch.
That's interesting, because I think all of us know people who are under 50 who have wrecked their knees through various kinds of trauma, cumulative trauma that eventually creates an internal inflammatory process. So I should go look at that, Clint, because I hadn't seen the 50 years old and plus, 50 years old and older. In terms of the pharmacologic pain medications, if kept constant, that's an interesting question, because as I've often said about this trial, one of the questions that really burns for me is if the participants felt that they could change their medication habits, and it looks from this exclusion or inclusion criteria that they could only stay in the study if they didn't change their medication habits.
That was 3 months prior, though, right? So they needed to make sure that they were
Stable.
Stable.
Yeah, right.
At least 3 months prior.
Yeah. Okay. But I mean, from the way this is split, and I'd have to go back and look at the study, but it looked like they wanted for people to keep using the pain medications that they had, or the pattern of medication use that they had developed to maintain that stability. In other words, we didn't get any data on whether the massage could impact whether people felt they needed their pain meds.
I think
just one other interesting point is the mean age was closer to 60, but it was very interesting that they were willing to include people 35 and up.
Yeah.
You're right. That is very interesting. So some great kind of questions have been raised as we move our way through the discussion here, which is part of the Journal Club. Everybody helping to chime in on different points that maybe each of us alone would have read it a little bit differently. But coming together, we can get a little clearer picture of the study. So moving on within the methods, this is basically a description of the study design, which was a randomized clinical trial, block randomized, with 8 weeks of treatment, and then follow-up at 16 and 24 weeks to really look for a possible sustained response after treatment. About 125 were enrolled in the study, split into 5 groups, each with progressive amounts of massage therapy, as small as 30 minutes once a week for 8 weeks, moving up to 60 minutes twice a week for 4 weeks, and then to once a week for 4 weeks. So I find this is an interesting way to grade it. So I thought I'd open this back up if anybody had a comment here on the study design or something they found really intriguing about this.
So first of all, in their original pilot study, that group 4, the 60 minutes twice per week for the first 4 weeks and 1 week after that for the next 4 weeks, that was the original dose that they looked at. And when you do, initially when you do pilot studies, you want to get stack the deck in your favor, if you will, to get the biggest response that you can measure. Mm-hmm. Okay, and so this was a very strategic way to do this. But for practical reasons, when you start doing a larger trial, that's going to become a very, very expensive intervention to do. And if there is a more effective intervention that is still accessible and used in practice that would be more appropriate for these other pieces, then that would be ideal. And so this is part of the reason they were doing this. And we certainly do 30-minute sessions in practice. We certainly do see people twice a week or once a week. And so trying to give as much opportunity as few groups as possible to get that optimal dosing was really key for them.
And the one piece in here, Nikki, that people may not understand is about the block randomized, and we don't want to spend too much time on it, but maybe you could comment on that.
Oh, it's a very systematic way of randomizing, and so it was between 2 different sites they were pulling people from, and so sort of going back and forth, making sure that it was being filled appropriately. But then they also did a stratified randomization, so that they were also looking at BMI to make sure that it wasn't heavy on one side or the other,
so to speak.
Right.
Perfect. Well, thank you for
Is there a correlation?
So we're going to move into a little bit discussion here around the protocol, which was presented in the paper, and this is a brief table kind of summarizing the protocol. But I think that in running through this ahead of time, we had a number of comments around the protocol. So I'll let somebody start it off.
Well, I'd like to just point out that this group chose to look at Swedish massage, and in an earlier companion paper about developing this protocol, they said that they chose that because it's been demonstrated to be relatively safe. It's a really, sort of a common approach that's taught in massage schools, which makes that, that many people have the skills to deliver this. And and those are good reasons for choosing Swedish massage as opposed to something that was maybe a little less specific about say as opposed to relaxation massage, which could encompass some skills, some specialized skills. So I appreciated that, and in developing, trying to come up with a way to, as Nikki said, to manualize this, they really decided that what they would do is prescribe what percentage of the session was set on each body region, but to let the therapist decide on the order and in what position their clients would begin. And to let that be the part that is the sort of individual clinical decision making that we make when we individualize our treatments. Clint, I know you had some more sort of stumbles in this, so I really want to hear what you say.
I mean, this would be a great example for the consultation group. So
could
I demonstrate this? Could I have them duplicate it? On some level, yes, but I would say that it would be difficult. I mean, I know that there's a description that they use the 5 basic strokes, but I don't know how many of those strokes they did. I don't know the depth of the pressure they used, the position of the client, the direction of the pressure. So there's for me, there's a lot missing in regards to being able to utilize the protocol as a stepping stone for a consultation group or teaching it in a class.
Well, I think that one of the nice pieces about what they've done here, though, is that they've really honored the way that massage is practiced. I mean, I might have somebody come to me with osteoarthritis, and I may see them several times, but each session isn't going to be exactly the same in regards to how many strokes I do and the exact pressure I use. It depends on the person in the moment. And so the sessions that I do for that client, but then somebody could come in presenting with the exact same on paper condition, but I'm going to approach them a little bit differently. And so I think by having this very broad protocol that's not a exact scripted piece, while it does speak to the black box that is treatment, not just in massage therapy, but in other rehabilitation.
In any individualized therapy, yeah.
Yeah, I think it becomes sort of a hard line to toe.
Yeah, I would agree with you, Nikki. It is. I'm just talking about from the student's perspective or from a practitioner's perspective. Duplication also is really critical, as you know, for research. So can you duplicate this? I don't know.
Well, you can duplicate it to a certain point,
right?
And
right.
with these pieces, and those are the pieces that they're outlining. But I would never want a research protocol or something from a research study saying, okay, students and okay, practitioners, this is the exact thing that you want to do with this many strokes and this kind of pressure in this area and this piece in order to get these results. If not, then what you're doing isn't worthy and isn't good.
Well, and what we've seen is research that looks at massage conducted in that way doesn't show particularly good results for massage, and it's not a surprise.
And there's a place for that. I mean, there is a place for those sorts of protocols, but it's in a very controlled research sterile environment. It's not for practice and real life human beings on our table.
Yep. And the other thing is that we were really talking about this is a dosage study, and so we are using something that is kind of common within many of our practices, a 60-minute or a 30-minute treatment. The other thing that is interesting is that this is a full body massage to treat a knee osteoarthritis. So that was something just to think about.
Right.
Well, I think that in our discussion, in terms of Clint's discussion, there is a companion paper of sorts came out a little bit after this one in terms of the development of the manualized protocol. So there is, Clint, you weren't the only one with the question in terms of a little bit more information, and that might help out a little bit.
Yeah, I think we sort of have to, at least I feel like I need to give credit for people who are educated in Swedish massage, Clint, especially in terms of your questions about pressure and direction, that there are traditions about that, and that we begin light and we warm up the tissue and then we go deeper according to, resistance and whatnot. And so with that with that scaffolding, if you like, then the freedom to improvise is given in the in which strokes the therapist felt were most appropriate and in which order of body areas that they wanted to proceed. But in terms of getting really specific about, are we going toward the heart? Are we doing, deep stripping before we've done any, lighter strokes or whatever? I think that that's something that we give to the tradition of Swedish massage.
Well, I think it speaks to a point that Clint made previously, not in this session, but the nomenclature. Well, what is Swedish massage? How are they defining Swedish massage? And is that the same way that is being taught here or there otherwise? And so it's also sort of highlighting those nomenclature issues that our field has. Is that appropriately assessing what you had said before, Clint?
Yeah, that is. Yeah, that's exactly right. Yeah.
And this is the main question. We were even in some of the research conferences, and people would say they would do Swedish massage, and that what was Swedish massage? So they did try to control for consistency throughout the study. So that it was an interesting part of the study as well.
Well, lots of great discussion around the protocol, which is great, part of the Journal Club experience here. So we're going to move on to the assessments portion of the methods, and really, taking a look at what was going to be measured. And the primary outcomes we were looking for is a change in WOMAC scores, and WOMAC stands for the Western Ontario and McMaster University's Arthritis Index, which is a common assessment tool. And then the secondary outcomes were the visual analog pain scale, range of motion, and time to walk 50 feet. The assessments were carried out at 4 time periods, and what I really liked in terms of the adding to study validity is the assessment was carried out by a blinded research assistant. In other words, they did not know, the assessment was carried out by somebody who was not aware of what treatment the patient had received.
Which of those 5 groups that they were in. Right.
Yeah. Which helps to add a little bit more and make sure that they reduce the amount of bias. The analysis was repeated measures, ANOVA, and post-hoc analysis was Duncan's multiple range test. Now, this is the benefit of a Journal Club is that we have multiple backgrounds, and so I know Nikki has some background in terms of the statistics then, and so
my favorite thing.
We can refer to her in terms of the validity of these analyses.
And I say yes. Without getting into a whole lot of detail, yes, absolutely. These are appropriate statistical analyses to use in this kind of study. So, thumbs up.
I also want to just remind our listeners that the study went for 8 weeks. So we got measures before the study began, at the conclusion of the study, and then is that can someone remind me? Is that 16 weeks? From baseline or 16 weeks from the end of the study? All right, so we got at the 16-week study is basically 2 months after it had concluded, and then the 24-week study would be a good deal out further from that. So
yes. So the study actually was 24 weeks long. The intervention portion of it
were 8 weeks.
Yes.
Yeah.
Yes.
Mm-hmm. And the unique one that I found interesting in this study was the time to walk 50 feet. I had never really seen that in a study.
Well, and I think they even commented that isn't necessarily the best measure to use, and they're probably going to shift that. That's a hard one to really get. It's not a very sensitive test for this sort of piece. Yeah.
Plus, you have an adaptation, right? Yeah, you have an adaptation to that activity. So.
Yeah, but I'd just on behalf of research clods like me, I'll say that I really love seeing functional outcomes. Mm-hmm. And, so for our clients who want us to help them with their knee pain, they are probably more interested in something like, can I climb stairs without pain, or can I walk 50 feet, can I cross the street before the red flashing guy comes on, more so than WOMAC scores, right? And so I maybe it's more appropriate, and it's almost certainly more appropriate for something, like a case report, where you have an individual who has specific goals. But I just love seeing functional outcomes that are sort of distinct from the clinical ones.
Well, to add to that too, Ruth, I say that they may not use this in the future, but actually it may be that with a larger sample and stronger statistical power, they would be able to see more of the subtle effects that would show up in a 50-foot walk test than they would in this smaller sample.
Mm-hmm.
So
yeah, or maybe shift it from not timing it, but do you experience pain?
Yeah, can you get through that without pain? How far can you walk before you have pain?
Yeah.
But they also have like sit to stand, like how many can you do this many sit to stands without pain in this amount of time, and that's another valid.
Yeah, I'm with you, Ruth, on the functional outcomes. I like it too. Yeah. Mm-hmm. The concern is just the ability to adapt to a test like that. To repetition, people get faster. We just know that from doing it. Yeah.
Great. Lots of good discussion on this topic. We're going to go ahead. So we've kind of gone through a lot of portions of the methods, taking a look at who was there, who was involved, and what the time period was, and also how this is assessed. So we're going to move on into the results section, which is really what happened, what we all want to know.
Well, I would point out one thing, and I meant to go back and look closer at this, but it really doesn't. We know that the massage therapists who were used in this study were massage therapists that were trained and certified, licensed, I think, in North Carolina. Is that correct? Anyway, but we don't know how many. We don't know the details of their education. We don't know the details of their scope of practice, and those sorts of pieces, which would have been nice. We knew more about the pilot study ones, those who worked in the 06 study. There was only 2 of them, but that would have been something nice to report.
You're right. That would have been an extra piece to add, maybe in the next study, report out on those qualifications.
We could probably call them and ask.
So moving onward into the results, we're going to break this apart, and this is going to be quite a bit of data. There's a lot of great results. So start out with some basics, and that 119 of the 125 completed the study, with the adherence rate defined as 80% of assigned visits. So the patients had to come to 80% of those visits to be considered complete. What they did a nice job of is in figure 1, the participant flow diagram, which really documents the dropouts and the loss to follow-up, and also highlights the intention to treat analysis that was carried out. And then also table 2 has some nice demographics to show similar groups after randomization. So some nice features in the study. I didn't know if anybody wanted to comment on that any further.
Those are good retention numbers, I can tell you that.
Amen.
Right.
Yeah.
Well, I mean, isn't that a big issue in massage therapy research, that we're great at retention, but we have unless someone's in the control group?
Oh, well, it's a lot of research, not just massage, but yeah, I mean, it's retention in general is challenging, but for them to have this small a loss to follow-up rate is really impressive.
Were they paid as well as receive massage? I can't remember.
They did have minimal compensation.
I think there was compensation. That helps too.
There was gift certificates for massage.
But
for more massage, yeah. Yep.
But if you note too, out of the usual care, they only lost 1 person. Out of 25, they only lost 1 person to follow up. Whereas
those are great numbers. Yeah,
in the first group, who was in the massage once a week, 30 minutes, they lost the most. They lost 3 out of their 25.
Mm-hmm.
Wow.
All right, so moving on to the heart of the results is our table, which is really the outcomes at 8 weeks. And I'm gonna let I think Nikki, you had mentioned maybe we could walk through this in terms of some differences that we might want to highlight as we move through looking at the table.
Okay, so there's several things that the table can tell the story of, and the first piece that's interesting is that all of the different massage groups did experience significant changes and improvements from baseline. Okay, and so we can tell that by, if you look at the WOMAC scores, so the pain, stiffness, functionality, and global, you see all these numbers, You see the first number in the column, so we'll start with that first, so that negative 15.1, and then you see these other numbers in parentheses, okay? So that first number, that negative 15.5, is the raw mean change for group 1 that happened, okay? And then you have this confidence interval. And this is the place where you're going to be able to see if there's the statistical significance here. If your confidence interval, so this is just a little stats trick, if your confidence interval does not include 0, then that is statistically significant, okay? Just for that particular number for baseline, and for this group for baseline, okay? So if you go across the different groups, you can see that each one of these groups, for example, with the Payne-Womack scores, none of those confidence intervals include 0. And so they were statistically different from themselves at baseline. But now let's take a look at the usual care in this regard. So they also had an improvement of 5.6, right? But when you look at the confidence interval, it doesn't include 0. So we know that that change wasn't statistically significantly different from 0, okay? But now, so this is great news, right? Okay, so they all improved. But you've got to be able to put this improvement in relation to something, okay? Because as we see for this particular line, we see that the usual care did have some improvement. And so now we have to compare the improvement in our groups to this usual care to see if those differences are statistically significant. And so this is where we see the little crosses now.
Oh, yeah.
So the little crosses are what are highlighting the statistically significantly different changes from groups compared to the usual care group. And you see that there's not a whole lot of crosses in this regard, but you do see that the crosses are stacked, if you will, on the groups that received 60 minutes of massage. Okay? So when you compare the changes made from those who had 60 minutes of massage to those who didn't have any massage, those changes were significantly different. Okay? But when you look at those who had the 30 minutes of massage compared to the usual care, those differences aren't statistically different from each other. So does that make sense?
Yeah.
Yeah, kind of.
Okay.
But I want to, can you just take a minute, and Deb, if we don't have time to go into this, then you can shut this down. But Nikki, I wonder, can you talk a little bit about the difference between statistical significance and clinical significance?
Sure, okay. So statistical significance is purely numbers crunch, okay? And really, if it's considering variability and all manner of things. I wish I had a chalkboard and I could draw bell curves and show you where the data lie and why that's.
Oh, I'm really glad you don't have a chalkboard.
But just because something, okay, so I'll get to the meat of it. So just because something is statistically significant doesn't mean that it clinically means anything. Because truly, if we inflated these numbers, if we had a whole bunch of participants, which of course we can't afford to do, when you start seeing changes, you're able to see statistically meaningful differences at a much lower rate. So these numbers could become much smaller for change, but now they're statistically significant. Well, it doesn't matter.
Because you have a larger N?
Yes, because you have a larger N and less variability, ultimately, or you'd expect. But what happens, especially when you start seeing these this inflated power to see these really small effects, does it clinically mean anything?
Right.
And so if somebody has a 5% change in something, that might not improve their functional outcomes or anything like that. So it's really important when you are looking at standardized measures that there has been tests, and there's ways to do this, to determine what is clinically meaningful change. And they talk about those pieces for the Womack score. And for the Womack score, it's been established that a 15-point improvement is considered clinically meaningful. And so from that perspective, if we now take a look at these numbers in the Womack scores, we see that each group had a mean difference that was clinically meaningful, except for this group 2 in the pain, and that's the only one. Now, when you go to the usual care, they didn't experience any clinical meaningful change in WOMAC. But here it still becomes important that we're accounting for the change that just happens by
natural
chance,
history,
or the Hawthorne,
Natural
Hawthorne
history
effect,
of the disease or whatever.
Right, right. So we have to account for that, and that's why we have to have this comparison group, and we do have to look at the statistical pieces to make sure that they're, because I can't finish that thought, never mind. I hate it when I do that.
Well, I appreciate the little tutorial, and I hope that the listeners got something out of it, because I sure did, so thanks.
And they do talk about that in the article. They really highlight that piece as far as the point change, but then also the percentage change, because truly the percentage change overall is going to be more meaningful too, because a 15-point change is going to look different for different people, right? Because if somebody only has 20 points to do anything with, when they have a 15-point change, that's huge, right? That's what, 80%. But if somebody has 75 points to change, that becomes only, what, 15, 20%, right? And so they also talk about the clinical meaningful change for the Oswestry is, oh shoot, I have it written down somewhere, what, 18% is clinically meaningful. And when you look at these results, their average results are anywhere from 44 to 50% change.
That's huge.
These hour groups.
Right.
So yeah, that is huge. That's really clinically meaningful, and as we see, statistically significant from the usual care. And let's go back to the results. We see these double crosses. We only see that in one place. Mm-hmm. This double cross indicates that this group 3 was statistically different from group 1 in this regard, so the 30 minutes. But when you did group comparisons, nowhere else were there statistically significant differences between the groups, other than usual care. So the punchline to all of this is they are looking for an optimal dose. Optimal dosing meaning that you're getting a good clinical outcome for the best value. And so while they see that there's statistical and clinical meaningfulness in those group 3 and group 4, you're still getting good effects. And in fact, we'll see in one of the next slides is that there seems to be a plateauing effect. So we might as well just do that once a week, 60 minutes once a week, rather than this twice a week piece that certainly does cost more. And truly for people, is it nearly as accessible?
Right.
Mm-hmm.
Right.
Great. Well, that was
thanks, Nikki.
A wonderful explanation. And again, one of the benefits of having a discussion in a journal club and getting together with colleagues is that everybody will see something a little bit different out of the tables, out of the text, and might take it a little bit different way. And discussing it really helps to clarify it for everybody. Mm-hmm. So again,
it gets easier.
Exactly.
It does get easier, and having some of those tricks too of being able to look at confidence intervals and know, oh, there's the statistical significance. That's helpful.
So this is one of the the biggest outcomes from this study is really this curve in terms of that dosage. And so did anybody else want to comment on these results in particular of that the dose of once a week, looking to be more of the optimal?
Well, I'd just like to say, in an attempt to simplify things for people who might read something like this and feel overwhelmed, that when we look at the optimal dose, what we're looking for is at what point does adding more really not make a big difference? And it was surprising to me that there was a really clear place on this chart where that was obvious, and B, it was something that we sort of already do, right? An hour a week.
Right.
So, and that what did not factor into this, I mean, they're just looking at the pain scores, right? And the WOMAC and they're looking at their measures. They're not looking at an entirely other aspect, which is the client's willingness to dedicate time and money to this, and that would feed into it. That would feed into an optimal dosing thing as well, in terms of there's no point in saying this is the best approach if people simply can't do it. So anyway, I thought this was really just a fabulously elegant outcome.
Yeah, and also coupled with that is probably the quality of life issues that you're probably referring to as well, Ruth. Do they sleep better? Can you participate in other activities, daily activities, stuff like that? Yeah.
Well, and Ruth, if I could go back to your point that you made, and I don't know the answer to this. Were these massages covered? I think the participants didn't pay for these massages. Is that correct? I don't think they did.
I can't imagine that they would.
Right, but in the real world, they would. They would have to, right? And so so that's a key piece.
Until the day comes when we make a compelling case that treating osteoarthritis manually, is as effective as other interventions that are more costly, and therefore, paying for our services becomes a cost-effectiveness issue for healthcare.
So I think this is a really great segue, Ruth, to the next slide, which I think is going to be the 24-week follow-up results. Is that right? Okay.
Yep, that is right.
So here's the thing with this: is while there's still improvement from baseline to 24 weeks for those who had the intervention, and that is statistically significant if you look at the confidence intervals here. When you start comparing it, though, to the usual care, that meaningfulness goes away. Statistical meaningfulness goes away. And if you also note, we just talked about clinical meaningfulness, right? Few of those scores now hit the clinical meaningful from a point change perspective. Because remember, we're
not getting 15s, right?
Right, we're not hitting the 15. Okay, so that's an important piece. And the Perlman group does a really nice job highlighting in this paper that this may suggest that maintenance work is needed, and that we can't tease that apart from this, but it warrants further investigation. And so this is a place, and here we know that getting 8 sessions of massage a cure for osteoarthritis does not make, right? And so this is a progressive condition, and therefore needs continual care. And so this is
managed. It's chronic.
Right, it's a management. Yeah, it's a management piece, and that isn't something that insurance companies like to talk about. It's not something that's a whole soapbox to get onto. But this is a really important table here that's highlighting that while there are still changes that happen, they're not statistically meaningful when you compare it to that usual care. And as you can see too, there's still some changes that are happening in usual care that are statistically significant. So you look at the visual analog scale and you see those confidence intervals, that lets you know that 11-point change, which by the way is awfully close to group 1 and 2 who had the 30-minute sessions, right? That's also statistically meaningful. And so those are things that's why you've got to look at it all together, and they do a really good job here too of saying that this study really highlights the continued need for these comparison groups. And they're absolutely right.
All right, so we're going to move along because we're still in the results section. So we're going to finish up with the results.
Well, we've been doing the discussion at the same time, so that's okay.
It's true, we have.
Yes, I guess you're right. We have. With the results, and this is really ties it all together, kind of a week by week, and presents it all in once. This and the dosing curve are probably 2 really great tables to kind of give you a snapshot, if you will.
And it's a great argument to take to our clients or their primary care providers about the benefits and the duration of effect and follow-up, and the benefits of follow-up care. So yeah.
Wonderful. All right, did Clint or Pete, did you guys have anything you want to add to the results?
No, I think this chart really helps people see that the 60-minute massages have a significant effect in the 8-week period, though.
Yep.
Very easy to see that.
I always find it kind of interesting, this usual care over here seems to peak around 16. It'd be interesting to tease that out.
Yeah.
So moving on in the discussion, we'll just finish up and then we'll get some questions. So if you have some questions, go ahead and type those in your GoToMeeting software on the right-hand side. We'll try to get to as many as we can here. So in terms of the discussion, they do a really great job at really summarizing and pulling it together as we've commented throughout the course of our discussion of the results. really to highlight that this is the first dosage study for massage therapy. They were able to reproduce the results from the 2006 study, and that all groups showed significant improvement from baseline, and those effects might actually be somewhat sustained into 24 weeks, but not statistically significant. And then we outlined those positive clinical significance of the results, that a positive change is 15 points. And here we saw some significant ones with the 60-minute groups as well as the percentage. The importance of the control group. And then really the nice thing in the discussion, they bring out some of the limits and the limitations to the study. A couple of them are the sample size itself, each group at only 25, and then also that this really looked at just Swedish massage and full body. So I'll let you all comment if there's anything that we wanted to add on that discussion before we move on and sum it up.
Well, one of the things that the group of us have talked about is whether there might have been a different outcome if there had been a group receiving a specialized protocol for the musculature around the knee. That wasn't the purpose of this study was to come up with was to find the optimal dose of Swedish massage because it's easy, lots of people do it, it's easy to find. But in terms of how is massage with osteoarthritis at the knee, that an interesting next question will be how do these findings compare to maybe a study that where we focus specifically on the musculature around the knee.
And so that would be a comparative effectiveness trial, which they're very interested in doing eventually. I say they, the very broad research interested days, not necessarily this particular research group.
Right.
So in the conclusion section really just sums it up in that in terms of they established an optimal dose really for 60 minutes one time a week. And then help verify that protocol for full body Swedish massage. So the real big question then that we'll kind of end with here is this clinically applicable to your practice? So I'll have each of you comment a bit on that, and then we'll move on more to questions from our audience here.
Well, I think very clearly for my students in school and anyone who's taking continuing education classes, this is a very interesting study for people who are working with folks who have osteoarthritis and communicating to them that there's some evidence that a 60-minute massage once a week could be helpful.
Anyone else?
I would just say the short answer is yes for me, is from my gerontological background with older adults, and certainly this is a population that does experience more of this sort of condition that just reinforces the import for that.
Yeah, I think it supports what we're doing in clinical practice. The one time a week is usually what most people can afford and what they can allow in their schedule to do.
Right, that's a great point.
And it just sparks so many follow-up questions for me about, when we get to the maintenance issue, how much do we need for maintenance?
Well, and what does that maintenance look like? So, Clint, you say that most people can afford once per week, but I tell you what, I would challenge that notion.
I'm not sure that,
that's true. And they barely, many people would barely be able to afford once a month. But if it were established, you get this initial 8 done. You see this kind of improvement. Now, to hold this improvement, if we could get insurance or Medicaid or Medicare to cover a monthly massage or even a quarterly massage or something like that.
Yeah, what does that look like?
Yeah, and what I mean by that is that you're making a recommendation, right, for you're doing a little bit more intensive up front, and then there'd be a maintenance part of it.
Potentially,
right. So that's the next. That's another question. Another question for me is can we track this to reduce medication use? Is there some way we can ask a question about whether people can delay needing a knee replacement? I mean, imagine the burden.
Or another replacement.
or a second replacement or whatever. I mean, imagine like the financial burden that could be lightened when you compare massage to compare 24 weeks of massage to a knee surgery. We get a lot of massages in.
Mm-hmm.
There are just so many possibilities here for us to move forward with. So.
Well, thank you all for that input. And yes, sometimes a good research study will lead to more questions, as you've just highlighted. And it should, right? So hopefully we've covered most of our objectives today in terms of what we set out to do. I want to highlight before we wrap up for some questions here is that we do have an upcoming webinar really geared towards educators coming up in January, looking at really teaching research literacy. So hope you will be able to join us for that one on January 13th. And I want to thank all of our panelists. And I know my colleague Jennifer's on the line, and we have some questions that were coming in. So I wanted to have an opportunity to get to at least a couple of them here. Jennifer, do we have a couple that we could start off with?
Yes, we do. When compared to no pain, these are not really that significant. 27% is not a great result. Should we not be targeting 70% differences? Even at 40 to 45%, that is quite low. And the additional comment is 720-minute massages are very expensive for the outcomes.
Would anyone of our panelists like to take that question?
I would. I'll kick this off. So to say that a 40% or 40, so and the way that I'm hearing this question is sort of disregarding the meaningfulness of a 40% reduction in somebody's pain. That could potentially be huge and life-changing for somebody. And while it doesn't necessarily hit that 100% reduction, it doesn't discount the kind of quality of improvement of life. And like we mentioned before, it has been established that as little as an 18% change in WOMAC scores constitutes clinical meaningful change. And clinically meaningful change is just that. It doesn't necessarily mean it's a dichotomous cure versus not. You know, this is problems that we even see in medication usage, is that we're seeing that even medications aren't 100% effective, right? And the thing that becomes problematic there too is that people keep elevating their dosage levels even to get a 40% or a 50% or a 60% reduction in pain. So while it's
I think it's great to set the bar high and
sure.
to keep developing our skills so that we can maybe, continually improve our clinical outcomes, which is why Swedish massage, might not be the single most effective way to treat arthritis pain at the knee. But that wasn't sort of the question of this report, of course. This report was asking a different question.
And it's also not massage that being used to cure it.
Right.
And it's pain. It's managing the symptoms associated with the disease that it's not getting cured.
Right.
So yes, and then to speak to the piece about the cost, absolutely, it is a lot of money. But if it's for the massages, so if it was 60 minutes of massage once a week, so it's 720 minutes. I don't know, how much does that cost? Probably a lot. So about we'll say $800. Probably take a little bit from that for 8 sessions. But how much does
surgery cost? How much does it
cost? Or medications cost? And then not only the cost in dollars.
It's not just the medications; it's the complications related to the medications.
Lost time at work too. Lost time at work.
Those sorts of pieces, and then the long-term damage that being on those medications for an extended period of time induce. But those are the next pieces too, is a cost-effectiveness analysis that they're doing with the study that's currently happening. So they can start looking at that cost piece. But I think the point is well taken that yes, having, if we could get higher percentages, sure, that would be ideal.
It would be really interesting, and I don't have the capacity to do this, to compare what other interventions for knee arthritis get in terms of clinical significant, clinically significant changes. So,
reductions in pain. Sure.
Reductions in pain. Yeah, to compare an arthroscopy or, basically anything short of a knee replacement, even to compare, NSAID use or whatever,
Mm-hmm.
to see what clinically different, sorry, I don't have the language that you have, but to see what differences happen when people use these interventions and compare them to what we saw here.
Well, that was a great discussion. Thank you for the questions. I think that was a really good way to highlight a lot of what we went through today. So we're running a little bit short on time here. So Jennifer, why don't we take one more question, and then we do have a record of the questions. We'll try to follow up as best as we can with those that have asked the rest of them.
Sure, Deb. Related, there's another question. It says, according to a study in UBC, 30% get better without intervention. 66+% was viewed as significant. True, this is a 1993 study, but this has not been challenged.
33% get better from University of British Columbia, I would guess.
Oh, okay, okay.
33% get better from what?
From usual care or no treatment?
I can read the question again. It just says, according to a study in UBC, 30% get better without intervention. 66% plus was reviewed as significant. True, this is a 1993 study, but that has not been challenged.
Okay, so first of all, the fact that 30% get better without treatment, right? So this is sort of the natural progression of pieces, and this is why having control groups are so important. So we don't know what the percentage improvement for this usual care group, what that percentage-wise, we don't know what that is here. But they are comparing it to things that naturally happen with the progression of the disease or Hawthorne effects or what have you. So while that particular study may not have been highlighted, they are certainly speaking and considering that in their study design here, right? What was that second piece, the part about 66% improvement? Say that again.
Sure. It says 66% plus was viewed as significant.
66% plus of what? So
yeah,
I guess
we don't
know.
We don't have enough information to.
Was it WOMAC scores? And so was it compared to an intervention? So there's a lot of missing detail in that question that I wish we had more of. And I think the question also said in UBC, which would sort of indicate that it was a journal, maybe, rather, or if it was done.
Yeah, if you can give us some more information, I'd love to see that.
Yeah, that'd be great.
And maybe if the questions could get sent to us, we could also respond to them.
Mm-hmm.
Yep, that would be great. We can go ahead and either send to this info@optimalintegration.org here, and we'll be happy to follow up with as many as we can with our panelists here. Or you can send them to me directly, which is dhill, D as in Deb, and HILL at acac.org. So thank you all for joining us today, and I'll send everyone that has registered a new email once this recording is available and up on our website and the slides. So look for that, and thanks to all of our panelists. Thanks for joining us today. I think this was a great discussion, and we'll see you in January. Thanks so much. Bye.
Thanks, everybody.
Thank you.